Now we will begin our session. It is my pleasure to introduce Dr. Alex Rhodalakis and the presentation about the changing classification and staging of endometrial cancer.
Dear Chairman, ladies and gentlemen, I would like to thank the organizing committee for inviting me. It's really nice and it's a great pleasure for me to participate in the 7th meeting of the Egyptian Society of Gynecology and the 7th MEMAGO meeting. I will introduce the topic of concerning the changing classification of and staging of endometrial cancer. I have nothing. We know that traditional staging in endometrial cancer and in most cancers is based on clinical and pathological and radiological imaging information that we have. And based on that stage is a prognostic factor. From the TNM classification that has been established there have been so many changes with in different kinds of cancers and especially endometrial cancer. In the new classification for endometrial cancer, established by FIGO 2023, we have the traditional endometrial staging system has been moved because they are agnostic. These traditional cancer staging systems, they don't know, they don't report, they are agnostic of parameters like tumor type, the tumor grade, the LVSI, and of course they didn't have the molecular alteration. The incorporation of all these non-anatomical parameters has been made by FIGO in order to attempt to make the staging more personalized, to individualize staging, and of course to get information about the prognosis and management of these patients, and of course just to align with the ESCO, ESP guidelines for the risk stratification of these patients. This is the FIGO staging. We're gonna explain all these changes that has been made by FIGO committee. The FIGO committee is based on anatomical distribution of the disease within the organ and of course with the spread. And the most important differences in that new endometrial cancer staging is the introduction of these non-anatomical parameters, meaning the histological type, the LVSI, and of course the molecular classification of the tumor. And of course is the subdivision of stages 3 to 4 according to the location of the tumor, meaning vaginal or parametrial, and of course with a report to the nodal metastatic disease status and all these parameters. Considering histological type, the endometrioid carcinoma of low grade is characterized by when we're talking about grade 1 and 2 and high grade for grade 3. And of course, it has been distinguished different histological types like clear cell, serous, mixed, and differentiated carcinoma and all these different histological types. We divide to non-aggressive and aggressive histological types. The non-aggressive histological types are composed of low-grade endometrial carcinoma, grade 1 and 2, whereas aggressive histological types are altogether the grade 3 endometrioid carcinoma, and all these are the clear cell carcinosarcomas and mesonephric GI mucinous carcinomas. The high grade, especially when we're talking about high grade endometrial carcinoma, grade 3, this is an entity, this is a tumor, this is a disease quite heterogeneous, which is most likely to benefit from the application of molecular classification, as we will see. The molecular classification, the molecular profiling of these tumors of grade 3 endometrioid carcinomas could discriminate from the good prognosis polymutated in early stage disease from a bad prognosis, the P53 abnormal type. Of course, the high-grade endometrial carcinoma that is falling to the category of non-specific molecular profile, when estrogen receptor are negative, they carry also a bad prognosis. considering the MMR molecular subtype, that we know that there is an evidence that grade in this kind of tumors does not matter. Those molecular classification, molecular profiling is suggested for, highly recommended for high-grade endometrioid carcinomas of the endometrium. Considering lymphovascular space invasion, this is a quite important parameter that is addressed in the new system. It has to be differentiated from the MELF pattern, the microcystic elongating fragmented pattern, as well as the retraction artifacts that it's quite common, especially in minimal invasive surgery. And we have to differentiate it. It is differentiated between substantial or extensive LVSI with focal or no LVSI. The recommendation is based on the WHO 2020 with more than 20 vessels where we're talking about substantial or extensive LVSI. We know that the molecular classification that has been proposed by the Cancer Genome Atlas classified the endometrial carcinoma into 4 categories. The polyultra mutated with somatic hotspot mutations or a very high mutational burden ultra mutated, which is tumors that who have an excellent prognosis. The microsatellite instability hypermutated, characterized by endometrioid carcinomas or undifferentiated with microsatellite instability, and they have an intermediate prognosis. And somatic copy number alteration, high serous, with a low mutation rates, and TP53 mutations with an unfavorable bad prognosis of these patients. And finally, the somatic copy number alterations low, which include endometrioid carcinomas, clear cell carcinomas with a low mutational burden, and this prognosis is quite ambiguous also. By using a simplified surrogate which contains of 3 immunohistochemical markers, the P53, MA6, and PMS2, and 1 molecular test, the analysis for pol mutation, we can surrogate and classify the endometrial carcinoma into 4 groups: the pol mutated, the MMR deficient, the P53 abnormal, and the non-specific type of cancers. The polymutated has a favored prognosis, and we know that, we have established that. The MMR deficient and non-specific had an intermediate prognosis, whereas the P53 abnormal indicates a bad prognosis and deteriorating prognosis. Carcinomas that are referring to polymutated group may benefit from due to the good prognosis they have, may benefit from a de-escalation of post-operative adjuvant treatment, whereas the P53 abnormal, due to the worse and bad prognosis they have, we have to suggest some increase or intensive therapy in order to benefit from this in that situation. In early endometrial cancer, we have to differentiate early and late endometrial cancer and the meaning of molecular classification. In early endometrial cancer, the presence of pathogenic mutations can modify the FIGO stage. Those for stage 1 and 2 tumors, that is based on the anatomical distribution of the disease, a pol-mutated endometrial carcinoma that is confined to the uterine corpus or with a cervical extension, regardless of LVSI, regardless of histological type, is classified as stage 1 polymutated, 1A. Whereas a P53 abnormal endometrial carcinoma confined to uterine corpus or any myometrial invasion, regardless again of LVSI, is classified as stage 2. On the contrary, on the other hand, advanced endometrial cancer cases based on surgical and pathological characteristics, they do not alter based on their molecular classification, although we can get some prognostic information about that. Those stage 3 and 4 cancers with molecular classification reveals P53 abnormal should be recorded as stage 3 and P abnormal or stage 4 respectively, as you can see in the slide. Stage 3 and 4 for which molecular classification reaches MMR deficient should be recorded accordingly as stage 3 disease. With the case of advanced stage pol-mutated endometrial carcinoma, which is a very rare category, which we do not know their clinical significance. We don't have evidence and knowledge about that. So, but it should be stated at stage 3 poly-mutated or stage 4 poly-mutated. Tumors that combine more than one molecular feature, and this represents 5% of the tumors, are polymutated and P53 abnormal and MMR deficient and P53 abnormal. These are classified, these are called the multiple classifiers, and these classified, they should be not classified as P53 abnormal because they have a good prognosis, because they retain the favorable prognosis of either a polymutation or the MMR deficiency. For tumors with both pathogenic polymutated or MMR deficient, we don't know we have a very limited data. We don't know the clinical significance of that. Those complete molecular classification, including polymutation, MMR deficiency, and P53 abnormal, is encouraged in all cases of endometrial carcinoma in order to stratificate, to evaluate the risk stratification of this tumor, and of course, modify the adjuvant treatment or systematic treatment. These are in the new staging system, the classification. Depending on the molecular profile of the disease, adjuvant strategies could be de-escalate or intensive or more intensive treatment after surgery. We have 2 randomized phase 3 trials, the ENGOT GOG3 Ruby and the NRG G1 keynote studies that show a significant, statistically significant 5 years of progressive-free survival with the addition of an immune checkpoint inhibitor in terms of pembrolizumab to a standard treatment carboplatin plaque followed by an ICI maintenance therapy in MMR deficient patients. And of course, there are some trials that are ongoing. We are expecting these results because these studies are not enough to extrapolate the results. And now when we're talking about stage by stage modifications that the new system has established, stage 1 is a disease that is restricted to tumors confined to the uterine corpus. Thus, stage 1A is tumor limited to the endometrial polyp, confined to the endometrial with non-aggressive histological types. This is quite crucial, non-aggressive histological types, meaning endometrioid carcinomas grade 1 and 2. Stage 1A2 include tumors of non-aggressive again histological type involving up to 50% of the myometrium with no LVSI or focal VSI. And stage 1A3 is a new entity, is those we called in the past double primaries, the synchronous ovarian, the synchronous endometrioid carcinomas. This is confined to the uterus and to the ovary. This is a simultaneous tumors with the condition that they follow these criteria: no more than superficial myometrial invasion, the absence of substantial LVSI, the absence of additional metastasis, and of course being unilateral tumors limited to the ovary with no capsule rupture or no metastatic disease. These patients are classified as stage 1-3, are good prognosis patients, that's why we classified them as stage 1. Considering stage 1P, tumors are non-aggressive against histological types with invasion of more than 50% of the myometrium with no or focal LVSI. And once a tumor is aggressive tumors within a polyp or confined to the endometrium without any myometrial invasion. Myometrial invasion upstages the cases of this to stage 2. So we have an increasing stage 2 in the new classification. The number of women with stage 2 can markedly increase because we do have the stage 2A, the non-aggressive histological that have invasion of the cervical stroma, like we did have before. Whereas the stage 2B is a non-aggressive histological type because substantial LVSI defined regardless of the local tumor spread. LVSI represents an independent and strong prognostic factor that is taken into account in this classification. Stage 2C are tumors represent aggressive histological type with any myometrial invasion. This is to compare with stage 1C, which aggressive again histological type without any myometrial invasion. For stage 3, the tumor is spread locally and regionally. Stage 3A adnexal infiltration 2A1 and uterine serosal infiltration 2A2. The nuclear system has established specific definition for that. The tumor involvement in the fallopian tube should be staged at stage 3A1 and representing the form of intramucosal spread. Of course, this has a controversy, and it has been debating between pathologists about that. But pathologists should be careful about to distinguish the tubal involvement by serous carcinoma or the presence of serous tubal intraepithelial carcinoma. Considering the uterine serosal involvement, that's defined by submesothelial fibroconnective tissue in the mesothelial layer, regardless of whether tumor cells may or present on the serosal of the uterus. Specific mention to lymph node status and important according to TNM classification, micrometastasis larger than 2 millimeters, micrometastasis from 0.2 to 2 millimeters or more than 200 cells, and isolated tumor cells, which does not upstage, isolate ITCs do not upstage the carcinoma, are less than up to 0.2 millimeters. Of course, ultrastaging is recommended, especially for the sentinel node approach, which is quite common nowadays for endometrial carcinoma, and it is encouraged. Stage 3B is divided in two substages. TB1 aligns with the previous stage 2B, characterized by involvement of vagina of the parametria, and 2B2 is involvement of the pelvic peritoneum. It's disease in the peritoneum, but into the pelvic, with a specific node extending to the upper abdomen. Stage 3C is divided depending on the status of the tumor, independent of the status of lymph node status, micrometastasis, macrometastasis, and isolated tumor cells. And low-grade, this is another, as we told before, low-grade endometrial carcinoma that will involve in both the endometrium and ovary, and matching the criteria that we mentioned before are stage 1A3 tumor. In case we do not fulfill these criteria, and we have these adnexal involvement, more than 50% of meiometrial invasion, or rupture of the capsule, or extra uterine and extra ovarian disease, these cases remain as stage 3 and require adequate treatment, comparing with the low-risk patients of 1A. The addition of extra substage in stage 4, we have stage 4B patient with extra pelvic peritoneal metastasis, distinguished from 2B2, with peritoneal involvement who did not extend beyond the pelvis. This is a quite common introduction. And stage 4A is, again, the invasion of bladder mucosa, whereas stage 4C, that distant metastatic disease. These are the changes that incorporated into the updated endometrial cancer staging. When performed the Pol mutation and P53 abnormal molecular group, we can increase or decrease the stage of endometrial cancer to stage 1 and 2. This is quite innovative in the new changing system. No changes occur, we don't have changes occurring in the higher stages 3 and 4. This is a comparison you can do. There are some discrepancies between the 2023 figure and the 2000 guidelines established by ESCO, ESTRO, and TSP. The ESCO, ESTRO, and TSP guidelines separates high-grade 3 endometrioid carcinoma from the non-endometrioid carcinomas, whereas the FIGO had two categories in one, and they named it as aggressive histological types. In both systems, the Pol mutation and P53 molecular group have affect the risk. And of course, the same does not apply to mismatch deficient and non-specific molecular profile, which is served to stratify patients by the ESGO guidelines. There are some advantages and disadvantages of the new system. Advantages of the new system is that it's quite clear that the endometrial carcinoma is not a single disease. All these parameters are important to management and prognostication. Of course, they made a functional algorithm that facilitate in order to establish the risk stratification of the disease. The expansion of categorization of stage 1, 3, and stage 4 disease account different types of uterine spread, depicting very accurately the extension of the disease and individualize the patient care. Of course, the inclusion of nodal involvement quite serious because, again, individualize the treatment and the management of this patient. And of course, the separation of tumors of double primary tumor is quite an innovation because we know that these patients have different approaches depending on the extent of the disease. But of course, there are some disadvantages of the new FIGO staging system. This difference is quite markedly different, perhaps quite more complicated than the prior version, meaning that the adoption is problematic, the translation, and of course, the generalization. There are comparisons between prior and new patient cohort studies. It's quite extremely difficult when to compare all the studies with the new study. And of course, there is a major problem with the premature incorporation of some variables that we don't know, that are still involving. We don't know the clinical meaning of this. Yes. The many cancer cases, of course, the tumor involvement is quite open. The involvement of the definition of LVSI is quite critical. This is not established yet. We adopted the WHO definition, but of course there are some other definitions by NCCN which is not quite clear. And of course, the main problem is the incorporation of molecular results in FIGO staging. There are some points of consideration because the molecular approach precludes staging as proposed for resource-poor settings. The methodology of determining the molecular group is not yet specified. There is a great variation of this variation, and all of these auxiliary tools have great variability in terms of access, workflow, and of course, DNA sequence assays suffer from long turnaround. And finally, the poll testing has become more widespread, where we have moved from the hotspot, from the simple hotspot sequencing to the whole full exonic sequencing with target next generation sequence panel. And we have the opportunity to introduce some new specific mutations, but we don't have this variant, the clinical significance of these variants. The new FIGO staging system is here. We have to face it, and we have to know its limitation, but its benefit. Thank you very much.